This part deals mainly with mobilization and relaxation techniques to the thoracic spine and the ribs. With its 12 vertebrae, it's the longest section of the spinal column. The first two vertebrae, however, form part of the cervical-thoracic junction, and the last two parts of the thoracolumbar junction. The most characteristic feature of the thoracic section of the spinal column is, of course, its close relationship with the thorax and ribs. From in front, we see in our model the vertebral bodies and their intervertebral discs, which are the narrowest in this section, corresponding to their relatively lesser mobility. Here we see a side view of the intervertebral foramina, the site of the spinal nerves. Behind the foramina, we see the articular processes with the articular cleft between them, almost precisely on the frontal plane. From behind, we see the spinous and transverse processes. We can see that the ends of the spinous processes are at the level of the vertebral body of the lower adjacent vertebra. The transverse process articulates with the rib belonging to the same segment. There are also articular facets on the vertebral bodies at their upper and lower edges. For example, the upper facet of the fifth thoracic vertebra belongs to the fifth rib, and the lower facet to the sixth. The intervertebral joint could ensure much greater mobility of the thoracic spine in all directions, but mobility is restricted by the large thorax, except for the last vertebrae. There, mobility could be less limited, but even here the range of rotation is not greater than in other parts of the spinal column. Pain points in the thoracic spine are situated mainly at the spinous processes and above the articular processes. We examine retroflexion, anteflexion, lateroflexion, and rotation. To examine retroflexion, the patient is seated with his hands clasped behind his neck. We grasp his arms below the elbows, lifting them and producing back bending. Palpating between the spinous processes with the other hand, we can feel how the spinous processes approach one another, and when we feel the first sign of resistance, we spring the joint. It's most important to move the patient in such a way that the vertex of the lordotic curve is at the level of the examiner's palpating finger. For mobilization, we prefer the patient to lie on his side. We now grasp his arms in a similar way and move him into lordosis with one hand, while with the other we fix the spinous process until we've taken up the slack. Press slightly against my arms and breathe in. Hold your breath, and now breathe out. Breathe out all you can, and relax. Once again, press against me and breathe in. Relax and breathe out. At the end of deep exhalation in a lordotic position, mobilization takes place due to the synkinetic contraction of the erector spinae. This is repeated 2 to 3 times. In rigid kyphotic thoracic spines and for self-treatment, it's most convenient to make use of the mobilizing force of the spinal erector trunci. The patient is seated with the thoracic spine straight, the legs in slight abduction, and his hands on his forehead resting on the wall. In this position, he breathes in, bringing the thoracic spine into slight kyphosis. This is followed by slow maximum exhalation, facilitating lordosis. Breathe in as deep as possible into this area. And now relax and breathe out. It's useful to gently stimulate the skin of the affected segment in order to make clear to the patient the area into which he has to inhale as deep as possible. If this exercise is properly carried out, the patient should feel a slight pain between the shoulder blades as a result of the maximum contraction of the interscapular erector spinae. This is a very effective mobilization, but in patients with a hypermobile low thoracic spine, it results in exaggerated thoracolumbar lordosis instead of straightening the thoracic kyphosis. A slightly more difficult but more specific technique aimed at the mid-thoracic spine has the patient seated erect, the cervical spine straight, his arms abducted and flexed at the elbows, and the forearms pointing upwards. By external rotation of his arms, he straightens up his mid-thoracic spine. In this position, the patient exhales deeply and at the same time increases external rotation of his arms. This results in maximum contraction of the mid-thoracic erector trunci, which the patient feels as a slight pain. With maximum exhalation, the abdominal muscles contract and fix the thorax in the erect position, avoiding thoracolumbar hyperlordosis and posterior tilt of the thorax. For examination of the thoracic spine into flexion, the patient is seated with his hands clasped behind his head, the elbows pointing forward. We grasp his elbows from above and bring the thoracic spine into a kyphotic position. With the other hand, we palpate between the spinous processes at the top of the kyphotic curve. After taking up the slack, this segment is sprung. We have to ensure that the apex of the kyphosis is the segment we are palpating. Mobilization employs the same technique. After taking up the slack at the restricted segment, the patient is told, "Look up and breathe in. Breathe in. Hold your breath and look down and breathe out." We can see that the apex of kyphosis is at the level of the palpating fingers. Look up and breathe in. Breathe in. Hold your breath and look down and breathe out. An alternative is PIR of the erector spinae on the side where we find trigger points. For the upper thoracic region, the patient is seated and we fix the transverse process of the lower vertebra at the affected segment with our thumb, while with the other hand we bend his head forward and slightly to the side and rotate it to take up the slack. The patient then is told, "Look to your right and breathe in. Breathe in. Hold your breath and look to your left and breathe out." Look to your right and breathe in. Breathe in. Hold your breath and look to your left and breathe out. For the lower thoracic spine, he has his hands clasped behind his neck. We thread our hand through the elbow onto his shoulder so as to turn him towards the restricted side. With the thumb of the other hand, we fix the transverse process of the lower vertebra on the affected segment. We take up the slack by anteflexion, side bending, and rotation and tell the patient, "Look to your left and breathe in. Breathe in, hold your breath, and look to your right and breathe out." And once again, look to your left and breathe in. Breathe in, hold your breath, look to your right and breathe out. For self-treatment into anteflexion, the patient sits on his heels and bends his trunk forward over his knees. The therapist touches the affected segment and thus tells the patient into which area he should breathe. Breathe into this segment. Breathe in deeply. And now breathe out. The patient can also stimulate the affected segment with his own finger. For side bending examination and mobilization, the patient is seated. We stand behind him and side bend him by moving his shoulder from the side. With the fingers of the other hand, we support his trunk from the side. With the thumb against the spinous process, we fix the lower vertebra of the restricted segment. This is sprung after taking up the slack. As the spine side bends, it rotates and brings the spinous process closer to our thumb, while the fingers must support the patient's trunk from the side. If, however, our hands are too small to reach the spinous process, we stand at the side to which we side bend the patient. With one hand on the patient's far shoulder, we side bend the patient from in front. With the thenar of the other hand, we fix his thoracic spine with the end of our thumb at the spinous process of the lower vertebra of the affected segment. Gaiman's rule is applied for mobilization into lateral flexion. Resistance increases in the even segments during inhalation, and mobilization takes place during exhalation. In the odd segments, on the other hand, resistance increases during exhalation, and mobilization takes place during inhalation. The latter effect, however, weakens in the low thoracic region. Hence, the patient is told in the even segments, look up and breathe in, hold your breath, and relax and breathe out. Look up and breathe in, hold your breath, and relax and breathe out. This alternative method can be used for mobilization as well as examination. Look up and breathe in, hold your breath, and relax and breathe out. Look up and breathe in, hold your breath, and relax and breathe out. In the uneven segments, breathe out, and breathe in. During this phase, mobilization takes place. Breathe out and breathe in. Here again, we can see the alternative position for a patient with a broad chest. Breathe out, and now take a deep breath slowly. For rotation examination and mobilization, the patient is seated astride at the end of the table and turns to each side. Care must be taken lest he deviates from the vertical axis. Under normal conditions, the range of movement may vary from about 40 to 80 degrees to each side. If there is movement restriction, we usually see that the line formed by the spinous processes is interrupted at the level of the thoracolumbar junction on maximum rotation. By this test, rotation of the entire trunk is examined. In reality, there's always coupled movement, mainly in the frontal and horizontal plane, including the entire lumbar spine, without the thoracolumbar junction playing a significant role. Movement restriction is caused mainly by spasm and trigger points of the erector spinae, the quadratus lumborum, and the psoas, which form a chain. Mobilization into rotation concerns mainly the erector spinae and is therefore almost identical with mobilization into anteflexion at the site of spasm. We therefore stand behind the patient, who sits astride at the end of the table with his hands clasped behind his neck. We thread one hand through his bent elbow to the far shoulder and turn him in slight kyphosis to take up the slack in rotation and tell him, "Look to your right and breathe in. Breathe in, hold your breath, followed by, look to your left and breathe out." Once again, look to your right and breathe in. Breathe in, hold your breath, look to your left, and breathe out. This is repeated, and after 2 or 3 repetitions, the patient actively rotates against our repetitive resistance. The decisive role played by the muscles can be demonstrated by relaxation of the quadratus lumborum or the psoas having the same effect on trunk rotation as rotation mobilization. For self-treatment, the patient sits astride the table with his hand on his head. He brings his head onto anteflexion, side bending, and rotation to take up the slack. Then he looks to the opposite side and breathes in, holds his breath, and then looks to the side of the mobilization and relaxes. By concentrating the summit of the kyphotic curve at the affected site, he focuses treatment on the affected segment. A traction thrust similar to that in the cervicothoracic region can effectively be applied to the thoracic spine. We stand behind the back of the patient who is seated and apply a cushion with its upper edge against the lower spinous process of the affected segment. With one hand on the axilla, we support the upper thoracic and cervical spine, and with the other, we grasp the patient's far hand and pull it towards the cushion. We now press the patient against the cushion with both hands to take up the slack. And with a brisk movement, we increase this pressure and produce longitudinal traction. Breathe in, and breathe out. The most important muscle in the thoracic region is the diaphragm. It has not only a vital respiratory function, but it's also very important for maintaining posture. Palpation, examination, and diagnosis of the trigger points is very simple. We stand behind the sitting patient, palpating the diaphragm from the abdominal cavity in an upward direction. Then, by lateral movement, we elicit twitch response and get a painful reaction if there's a trigger point. For PIR, the patient is seated. He breathes in slightly, then squeezes his nostrils, and together with his mouth shut, breathes in deeply against the resistance and holds it for about 10 seconds. This is followed by unplugging the nostrils and breathing out slowly. When the patient masters this, he can repeat the procedure without squeezing the nostrils, but he can close the glottis as if he were pronouncing the letter K. After repeating this 2 to 3 times, the patient is asked to exhale all the air with force to achieve reciprocal inhibition. If the diagnosis is correct, the diaphragm trigger point always disappears after treatment. The spinal erector trunci consists of many muscles. Its superficial layer is formed by long muscles under voluntary control, and the deep layer, which is mainly concerned with posture. Painful trigger points, mainly in the superficial layers, are examined by snapping palpation. The areas painted red are those where the patient feels pain. The techniques described for flexion mobilization on the side of spasm and for rotation self-mobilization serve the same purpose. Gravity-induced self-treatment can also be applied with the patient prone, his head over the edge of the table. Lift your head and breathe in. Breathe in. Hold your breath and let go and breathe out. The higher the patient lifts his head, the more caudal sections of the back muscles are activated. Examination of the pectoralis major starts with examination of trigger points and painful attachment points, which are located on the axilla and at the sternocostal joints. Here we see the examination of the clavicular part of the pectoralis major, and this is the attachment point of the sternocostal part. The trigger points are examined by a pincer movement, i.e., snapping palpation between the thumb and the forefinger. Gravity-induced relaxation is the first technique. For relaxation of the sternocostal part, the patient raises his arm in an oblique upward direction to take up the slack, then slightly lifts his arm and slowly breathes in, holds his breath, and lets go and slowly breathes out. Lift your arm slightly and breathe in. Hold it, breathe out, let go, and relax. This he repeats and then actively pushes his arm down. For relaxation of the subclavicular part of the pectoralis, the patient stretches his arm sideways, taking up the slack by gravity. He then slightly lifts the arm and slowly breathes in, holds his breath, and then lets go, breathes out, and relaxes. Lift your arm slightly and breathe in. Hold your breath and breathe out and relax. This he repeats and then actively presses his arm down. It can be very useful to relax specific fibers which attach at the sternocostal joints. For this, the collage Moïse technique is particularly effective. The patient lies on his side with his back along the edge of the table. The therapist supports his back and at the same time fixes and stimulates the iliac crest with his forearm, while the other hand abducts the upper extremity in the direction of the fibers harboring trigger points, resisting adduction and at the same time stimulating the elbow. After stimulation, he tells the patient, "Press against my hand, breathe in, and relax." This is done several times, and in the end, the patient may push against the therapist's resistance into abduction for RI. When examining the pectoralis minor, trigger points may be found at the attachment points at the ribs in the medioclavicular line, and there's a pain point at the coracoid process underneath the clavicle. We use gravity-induced relaxation. The patient is supine with the affected side at the edge of the table so that the upper extremity hangs down, taking up the slack. The patient lifts his shoulder above the horizontal and breathes in slowly, holds his breath, and then lets go during exhalation. This he repeats and then pushes his arm down toward the floor. And now, examination and relaxation of the serratus anterior. Trigger points lie close to the attachment points at the ribs in the axillary line. The patient lies on his side, the upper leg flexed with the knee on the table and the arm raised. We grasp it above the elbow and take up the slack in the direction of the fibers which attach at the pain point. Press slightly against my resistance and breathe in. Breathe in, hold your breath, and breathe out. Press slightly against my resistance and breathe in. Breathe in, hold your breath, and breathe out. Gravity-induced relaxation serves for self-treatment. From the same position, the patient's arm is raised, taking up the slack by its own weight. The patient then slightly lifts it and slowly breathes in, holds his breath, and then lets go and breathes out. Lift your hand and breathe in. Breathe out and relax. For RI, the patient presses his hand towards the floor. Examination and relaxation of the latissimus dorsi and the teres major. Trigger points are found in the axilla where they are easily examined between two fingers. It's rare to find any on the back. Gravity-induced relaxation can be applied with the patient lying on his side on the edge of the table. He lifts his arm bent at the elbow, taking up the slack by its weight. He then slightly lifts his elbow and slowly breathes in, holds his breath, and then lets go and relaxes. For reciprocal inhibition, he actively pushes the arm downwards. Examination and relaxation of the quadratus lumborum. For screening, we look for trigger points at the side of the patient's trunk, supine or prone. For exact palpation, the patient lies on his side at the edge of the table. In order to increase the distance between the iliac crest and the lowest ribs, the patient grasps the end of the table with his hand and lets his upper leg drop over the edge. In this way, the deep trigger points of the quadratus lumborum, even below the ribs, as well as its attachment point at L5, can be examined. Gravity-induced relaxation is most effective. From the position described for examination, the patient may lift the leg, breathe in slowly, hold his breath, and then let the leg drop and breathe out. And after repeating this maneuver, he pushes the leg down towards the floor. Usually, we prefer the patient to stand with legs apart and to relax into maximum side bending from the affected side with his arm behind the trunk on the convex side. The head, too, is side bent. He now looks up and takes a deep breath, holds his breath, and then looks down and relaxes. If he is indeed well relaxed, looking up and deep inhalation is sufficient to straighten him up automatically, and looking down and exhalation to bend down. After repeating this 2 to 3 times, he pushes his arm towards the floor for RI. Examination and relaxation of the iliopsoas. Trigger points are examined by pressing our fingers into the abdomen towards the spinal column, where we feel resistance and the patient reacts with pain. The iliacus is examined in the lower abdomen against the innominate. For relaxation, we make use of gravity. The patient is supine with his buttocks at the end of the table. He grasps the knee on the non-affected side and draws it towards his abdomen to obtain fixation of the pelvis. The other leg hangs over the edge of the table with the knee bent, taking up the slack by gravity. He now slightly raises this leg, takes a deep breath, holds his breath, and then lets go and relaxes. Lift your right leg and breathe in. Hold it, and breathe out and relax. After 2 to 3 repetitions, he pushes his leg towards the floor for RI. Quadratus lumborum, psoas, and erector spinae form a chain, and relaxation of this muscle group restores trunk rotation. Examination and relaxation of the recti abdominis. Trigger points are examined by fast snapping palpation throughout the whole length of the muscle. Painful attachment points may be found at the xiphoid, and at the cranial edge of the symphysis from the abdomen. For relaxation, we make use of gravity. For the upper part, the patient lies supine with his legs slightly bent. He lifts his head, takes a deep breath, holds his breath, and lets go and breathes out. After repeating 2 to 3 times, he presses his head against a cushion. We may begin by examining pain points. These are found primarily at the angulus costae with the scapula abducted. Then follow the attachment points of the large muscles, the serratus anterior at the side, and the pectoralis minor in front of the thorax. After this, mobility can be palpated between the ribs during inhalation and exhalation. In the lower thoracic region, it's a wing-like movement. In the upper, the ribs move up and down. The most important point for diagnosis of movement restriction is that maximum inhalation as well as maximum exhalation stop sooner at the affected side. Here we can see rib blockage during exhalation on the right side. In the upper thoracic region, we frequently find the overtake phenomenon. Palpation often reveals asymmetry. We then usually find that the rib which was originally lower overtakes the other during deep inhalation. Movement restriction is, of course, on the side which has been overtaken. This can be examined with the patient supine or seated. In this case, we observe restricted movement and therefore blockage on the right side. Mobilization of the blocked rib is carried out by springing during exhalation. After mobilization, we make sure that the movement of the ribs is symmetrical on both sides. Most frequently, however, we examine the upper ribs with the cubices technique. The patient is seated, we stand at his non-affected side and grasp the far elbow across his chest, lifting it into retroflexion to take up the slack. With the fingers of the other hand, we fix the patient's second to fourth ribs through the scapula at the level of the angulus costae, and after taking up the slack, we spring it. In this way, we diagnose the pathological barrier. The same technique is also used for extension mobilization. The patient lies on his side with his legs flexed, the upper elbow lifted. We grasp his elbow and extend it to take up the slack. The other hand fixes the affected rib. Now the patient is told, "Press your elbow against me and breathe in." Breathe in, hold your breath, and slowly breathe out. Mobilization takes place only at maximum exhalation owing to synkinetic contraction of the erector spinae, as during extension of the spine. This technique is effective for the first 5 ribs. In the lower ribs, it's better to produce distraction of the transversocostal joints by pressing on the angulus costae during trunk rotation. For this, the patient is seated astride the end of the table with his hands clasped behind his neck. We stand behind him and thread our hand through his bent elbow to the far shoulder and turn him towards us to take up the slack. The thumb and thenar of the other hand is on the angulus costae. After taking up the slack, we may spring the rib with the thumb and the hand on his shoulder into rotation, or we may deliver a thrust. There is also a very effective thrust technique for the upper ribs, with the exception of the first. The patient is supine with his arms crossed over his chest. Manipulation is carried out against the thenar of our one hand. Here the thenar serves as a firm contact. This is ensured by pressure of the thumb against the metacarpophalangeal joint of the little finger. In this position, the thenar is placed under the angle of the restricted rib. Our upper hand, which presses on the lower elbow of the patient's crossed arms, must lie vertically above the thenar of our lower hand. The slack is taken up by the patient's weight, and we deliver the thrust with our chest through our hand to the thenar of the lower hand. The lumbar spine is formed by the last 5 largest vertebrae, which increase in size in a caudal direction. From in front, we see the vertebral bodies with wide intervertebral discs, the widest being usually between L4 and L5, which explains the great mobility of this section. On both sides there are transverse processes. The last disc connects the lumbar spine with the sacrum, which is part of the pelvis. Looking from the side, we see the lordotic curve of this section. Behind the vertebral bodies, we see the intervertebral foramina with the spinal nerves and vessels. The sides of the intervertebral foramina are formed in front by the disc and 2 adjacent vertebral bodies, above and below by the radix arcus or pedicles, and from behind by the articular processes. We have to distinguish the upper and lower articular process. From behind, we see the spinous processes, and on both sides the vertebral arch. Above and below the arches, we see the upper and lower articular processes and the articular cleft between them. Between the two lower articular processes, we can see the vertebral canal. This is where the lumbar puncture is performed. On both sides, again, we see the transverse processes, the largest usually at L5. Pain points are usually found at the side of the spinous processes. And above the intervertebral joints. Tenderness of the deep structures is better examined by springing the vertebrae, which enables us to feel resistance. If there's both, tenderness and resistance, joint movement restriction is the most likely cause. If, however, there's tenderness and normal springing, disc lesion is the more probable diagnosis. To spring a vertebra, we put 2 fingers on each side of the spinous process and put the ulnar side of the other hand across them. Then take up the slack and spring with the extended arm from above. This test can also be used in the thoracic spine, where it may also serve for mobilization and even to deliver a thrust, always at the lower vertebra of the affected segment. If we conclude that disc lesion is the likely diagnosis, traction is indicated for the lumbar spine, and if, indeed, traction causes relief, it confirms the diagnosis. If anteflexion is well tolerated, manual traction in flexion over our knees is carried out. The patient is supine on a low table or on a mat on the floor with his knees over the therapist's thigh, close to the knee. The therapist's foot is close to the patient's buttocks. The therapist presses the patient's leg close to his foot as a lever, lifting the buttocks free from the ground and making sure that they can swing freely. After this, he rhythmically increases and decreases his pressure on the patient's leg, affecting intermittent traction in flexion. If the patient's bent knee is exactly over the therapist's thigh, the lever is so powerful that the maneuver isn't tiring for the therapist, and the patient should feel relief. If extension is well tolerated, intermittent manual traction is indicated. The patient, prone, grasps the end of the table with his hands. The therapist stands at the other end and holds both feet above the ankles, which he must not squeeze. The therapist first makes sure that the patient is fully relaxed and then pulls the patient's feet slightly, letting them spring back. This is to find the individual springing rhythm of the patient. It must be felt not at the patient's hands, but in the low lumbar spine. The rhythm varies according to the height of the patient. This rhythm must be sensed by the therapist. Throughout the procedure, the patient should feel no pain, but if he does, we stop. We test whether he tolerates rhythmic traction of only one leg better. The procedure which is tolerated best is then used for treatment. Another method is isometric traction with the patient prone his head at the edge of the table. The therapist stands in front of the patient's head with his hands on the iliac crests and buttocks. The slack is taken up by pressure from above, and the patient is told, breathe out, and slowly breathe in. During exhalation, resistance increases owing to synkinetic contraction of the erector spinae. In the course of exhalation, we can also repeatedly press further. During inhalation, there's relaxation. The buttocks move in a caudal direction. If we have difficulty in reaching the patient's buttocks, we can stand at the side of the patient with our hands crossed, one hand against the thoracic spine, the other over his buttocks. Breathe out, and now breathe in slowly. Here we can see distraction taking place. And breathe out. During self-traction, the patient lies prone with the pelvis over the edge of the table. He starts with expiration, during which he lifts his buttocks. During deep inhalation, the buttocks drop, and relaxation and traction of the lumbar spine takes place. Breathe out, and take a slow, deep breath in. Restricted segmental extension is diagnosed with the patient lying on his side, the legs bent at an angle of about 100 degrees at the hip, and the knees flexed over the edge of the table. We fix the patient's knees with our thighs and place the reinforced fingers of both hands on the spinous process of the upper vertebra of the movement segment concerned. Exerting slight pressure against the patient's knees while fixing the spinous process, the slack is taken up. To spring the segment, we straighten up at the hips and with our trunk deliver a little synchronous thrust against the patient's knees and the spinous process. There's no springing in the affected segment. Using the same technique, we mobilize into extension. In the position just described, the patient is told, push slightly with both your knees against my thighs and breathe in. Breathe in, hold your breath, and relax, and breathe out. While the patient exerts pressure, he increases lumbar kyphosis. Once he relaxes, our fingers sink into the lordotic curve. This is repeated, and we then can feel that the segment springs normally. Rotation mobilization is widely used to treat restricted extension. It produces gapping of the lumbar intervertebral joints. The patient lies on his side, the lower leg only slightly bent, the upper in flexion so as to have the toes supported at the bend of the lower knee. We fix the patient's knee by our thigh, while with our elbow, his great trochanter, and our fingers are on the spinous process of the lower vertebra of the restricted segment. The other hand is on the patient's shoulder, who flexes his arm around our forearm. The slack into rotation is taken up by telling the patient to look to the right at an object which he can see only if he turns that way. Then he's told, look to your left and breathe in. Breathe in and hold your breath. Now, turn to the right and breathe out. After taking up the slack in rotation, we may also deliver a thrust at the patient's shoulder into rotation. More frequently, however, we use repetitive mobilization. The patient actively rotates his trunk rhythmically in the restricted direction, and we maintain fixation with the elbow at the greater trochanter and our fingers at the spinous process of the lower vertebra of the restricted segment, which we now can reinforce with the other hand. Fixation is so effective that we can reliably determine the segment which we mobilize. This active repetitive movement produces reciprocal inhibition. For examination of the lumbar spine into flexion, the patient lies on his side, with his legs bent at the hips and knees. Flexion is carried out by pushing the patient's knees against his chest with the shoulders fixed by our elbow. With the fingers of the same hand, we palpate between the spinous processes and feel them moving apart. The other hand on the patient's buttocks increases lumbar flexion, and, after taking up the slack, we spring the pelvis into flexion, the fingers of the other hand feeling springing, or the lack of it, between the spinous processes of the restricted segment. By mobilization into flexion, we also relax the lumbar part of the erector spinae, which in turn relieves painful muscular attachment points. This technique requires only very little rotation, mainly traction and flexion. For this reason, it should be used on the painful side in root pain and in most painful conditions. For mobilization, the patient lies on his side. The lower leg is flexed while the upper leg hangs down over the edge of the table, bringing the pelvis into an oblique position. By pulling the arm forward, we increase kyphosis, taking great care not to disturb the oblique pelvic position. We thread the hand nearer to the patient's head through his elbow, placing the thumb on the spinous process of the upper vertebra of the treated segment. We tell the patient to look up at the ceiling. The hand on his buttocks takes up the slack, increasing kyphosis, traction, and some rotation, while the thumb fixes the spinous process. Now the patient is told, press your buttocks against my hand and breathe in. Breathe in, hold your breath, and relax, and breathe out. During relaxation, the distance between the therapist's hands increases. This is repeated 2 to 3 times. The same position is also used to deliver a thrust. The same position can be used to stretch the lumbar erector spinae. For this purpose, we fix the spinous process of T12 or L1 with our thumb, and after isometric resistance, the patient not only relaxes, but is being actively stretched. For this purpose, it's useful to raise the table so that the therapist can place his thorax against the patient's trunk to increase kyphosis and stretching. The position into which we bring the patient for flexion mobilization is very useful for self-treatment. The patient looks at the ceiling and may hold on to the edge of the table with one hand. He then raises the leg which hangs over the edge of the table and breathes in slowly, holds his breath, and relaxes and breathes out. This he repeats, and for our eye he actively pushes the leg towards the floor. This technique also relaxes the lumbar erector spinae. Self-mobilization with the patient standing can be very specific. The patient stands with his legs apart. If restriction is in the low lumbar region, he puts both his forefingers over the upper end of the sacrum, L5 or even L4. In this way, he fixes the lower vertebra of the restricted segment. Rhythmic back bending against the resistance of his hands produces mobilization. Self-mobilization into lateral flexion is carried out in a similar way. If restriction is in the upper lumbar region, he places both his thumbs vertically from below with their tips on the spinous process of the lower vertebra of the affected segment for fixation and mobilizes it by rhythmic back bending or against one thumb by side bending. Mackenzie's method, though less specific, is very useful for its simplicity. Here we shall only describe the basic techniques for patients without side deviation of the pelvis. Standing, the patient fixes his buttocks with both hands for rhythmic back bending. More frequently, we indicate extension with the patient prone. The patient lifts himself by stretching both arms, letting his buttocks hang as low as possible. If this isn't painful, he breathes out deeply, increasing lordosis by synkinetic contraction of the spinal erector. This he repeats 10 times and doing the exercise up to 10 times daily. For flexion, he sits obliquely on a chair so that he can grasp the leg of the chair with his hands. He bends his trunk between his abducted legs and pulls himself further down by bending his elbows 10 times. This should be done about 5 times a day. It's important in this exercise that the pain mustn't irradiate into the periphery. Regular daily exercise is mandatory. Mobilization and relaxation techniques of the thoracic and lumbar spine were demonstrated in this chapter. This is followed by Chapter 3, in which you will learn diagnostic and therapeutic procedures in the pelvic region.